Our next section is abdominal radiology. Now, the most important thing about abdominal radiology for the Step 2 student is not to concentrate on how am I going to identify that lesion, but more on what were the different diseases that I studied in gastroenterology and in surgery that I can now better understand. You might be asked to identify a few images, but the most important thing is to be able to understand the other diseases. Now, our first scan is simply a normal CAT scan. This is a normal CAT scan where we're going lower and lower and lower and lower in the body and making progressive cuts. Now, in this form of CAT scan, the cuts are about 1 centimeter apart from each other, and it's like putting the body on a big bread slicer as we're slice down the body. Now, this structure is the stomach. Most common wrong answer is spleen. That's the spleen. This is the stomach. How do I know it's the stomach? Because there's air bubbles in it. There's air bubbles in that stomach. There should be no air bubbles in a spleen. This is the liver. This is the back of the lungs, and that's why it's dark. It's dark because it's air space. Because if it's lighter and more like air, it'll come out darker. Rib, spinal cord in the center, vertebral body, rib, spleen, liver, spleen, stomach, liver, spleen, stomach, liver, spleen, stomach, liver. Gallbladder over here. These are paraspinal muscles, and these are what are keeping you standing upright. Why don't your ribs flop over like a slinky? Because you have paraspinal muscles and the slinky doesn't. And this is all liver. This is not abnormally enlarged. This is normal. Normal abdominal CT scan. This is also normal, showing you a different cut. This is the liver. This is the vertebral body, the cord, the rib, the paraspinal muscles. You notice how liver and ribs comes out to be in between the density of bone and air because that is what its density is. It's in between bone and air. These are blood vessels in the liver. These are hepatic vessels coming out from here, from the pedicle here, going through the liver. And this again is a normal CAT scan of the liver as we're going up towards the head, and that's why we're seeing a greater amount of lung. On the previous image, we only saw a tiny amount of lung, which got less and less, the tiny little bit of lung back there, to almost nothing at all as we go lower down in the abdomen. Here it's higher up, so we're just seeing the top of the liver, and this is the lung. This has gone down into the abdominal contents. This is a spleen. This is the crus of the diaphragm. Crus as in C-R-U-S, like where we get the word crusader from, or cross. The crus of the diaphragm. This is a blood vessel. This is the vertebral body, spinal cord, rib. And this is the gallbladder, not this. This is just a different piece of the liver. This is the gallbladder. This is the liver. This is the pancreas. This structure here is the pancreas. Head, body, tail of pancreas, spleen, crus of diaphragm. Normal. Now this is here to show the normal pancreas so that if there is pancreatic pathology, you'll be able to recognize it. Now this shows you that when you have seen a normal CT scan in the abdomen, such as this one, that when you finally see an abnormal, it jumps out at you. This is a hepatoma and multiple abscesses. This is effusion. This dark stuff here is ascites. And when you have effusion in the abdominal cavity, it's ascites. So the dark stuff is fluid. Now, you might say, well, why isn't the fluid gone to the back? Because it can't get there. This is a big spleen. This is the liver and a hepatoma. These are abscesses. This is a spleen. Liver, spleen, effusion, otherwise known as ascites, and a hepatoma. This is a very abnormal CT scan. Now, this is an abdominal film. You'll notice that you can't see the top of the diaphragm. And the top of the diaphragm is not always visible on an abdominal film. The top of the diaphragm is always visible on an upright chest X-ray, but not on an abdominal film. Now, this is very subtle. This is not the abnormality. That is a normal bowel gas pattern. Most of that gas will be reabsorbed in the colon. Did you know that you make 2 liters of flatus a day? Yes, you. Even nice girls make flatus, but you reabsorb most of it and don't express it. Only about 200 milliliters, basically a cup or two of flatus, is expressed. Hello, just a cup of flatus a day. But about 2 liters is produced and most of it is reabsorbed. So this is a normal bowel gas pattern. You notice there's no straight lines. There's no air fluid levels. There's no straight lines in there. That's why it's normal. Abnormal bowel gas patterns have straight lines because the bowel's not moving and all the contents just stay there, like the Florida Everglades or Louisiana swampland. It just lays there flat. But this is a normal bowel gas pattern. This is the hip down here, this is the iliac crest, and this is your sacrum, which spaces for the spinal nerve roots to come out of. Of course, these are the vertebrae and these are the ribs. The abnormality here is very subtle. It's up here. These little white dots, these teeny little white dots, is what chronic pancreatitis looks like on an abdominal X-ray. These little white dots are what chronic pancreatitis looks like on an abdominal X-ray. Very subtle, very small. This is what chronic pancreatitis looks like on an abdominal X-ray. And it also shows you why abdominal X-rays are not very useful except for looking for obstruction. This is a CAT scan of the same type of patient. Here's the gallbladder, here's the liver, here's a kidney, and here's another kidney. You'll notice the kidneys are not at the same size because on the right side, the liver shoves the kidney down lower into the abdominal contents. Whereas on the left side, there's no liver above it, so the kidney rises up. So this is the bottom of the left kidney and the middle of the right kidney, because this one is lower because the liver shoves it down. This is a gallbladder. This is a spleen. This is a calcified chronic pancreatitis, a beautiful shot of calcium, calcium, calcium in the head, the body, the tail of the pancreas. Most accurate test, it would actually be a secretin stimulation test. You put a catheter in someone's nose, and when you put the catheter in someone's nose, you can inject secretin, and secretin will cause the release of bicarbonate from the pancreas. So this is a abdominal CT scan showing the calcifications. However, it's not as accurate as a secretin stimulation test, looking for bicarbonate to be released from the pancreas. This is a pseudocyst. You'll notice that there's no wall around it. It must be something. Look at those arrows. You would not get this by itself. It wasn't for the fact that I showed you pancreatitis, chronic pancreatitis, and pseudocyst. Crus of the diaphragm, rib, 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 vertebral body, spinal cord, blood vessel, liver, pseudocyst. If it's symptomatic, you drain it. If it's enlarging, greater than 5 centimeters, you drain it. If it's small and asymptomatic, you leave it alone. Small means under 5 centimeters. Large means over 5 centimeters. If it's enlarging or it's painful, you drain it. If it's small and asymptomatic, you leave it alone. Pseudocyst of the pancreas. This is an abdominal film. You notice that there's straight lines, straight lines, straight lines. And the straight lines are the obstruction. This is a small bowel obstruction. And since this is a small bowel obstruction, you could see the air fluid levels in the bowel because the whole thing is obstructed with an ileus. This is a small bowel obstruction, and this is an ileus, and there's nothing to do specifically to make this better. NPO, nil per os, NPO, don't feed them. Maybe nasogastric suction. Correct the electrolytes such as calcium, magnesium, potassium, and wait for the bowel to come back to life. There's straight lines. There is very little that's natural in the human body that has perfectly straight lines. Most things have a curvature to them. So it is not much that's naturally straight inside the human body in terms of a straight line. Naturally, it's curved. So the bowel gas pattern, as we've looked in our previous films, there's no straight lines there because there's no air fluid levels because everything's going forward. Whereas here, there's no forward movement. This is an ileus or small bowel. Straight line, air fluid, air fluid. This is a barium enema. And the barium enema is showing what should be a colon cancer. Now, some people call this string sign. Some people might call this an apple core lesion, like a bite of an apple here and a bite of an apple there. Now, that's really an apple core lesion, a bite of an apple there and a bite of an apple there. And this is a circumferential colon cancer pressing against the colon. This also is a circumferential colon cancer, making it so that the barium, which is coming up from the rectum, up from the rectum, up from the rectum, up from the bonk, and it can't get through. So this is a string sign of barium not passing into the circumferential colon cancer. This person needs a colectomy right away. Get rid of this colon cancer. Same thing here. Get a colectomy right away. Circumferential. Cancer here, pushing in the bowel. Barium, barium, and obstruction. This is an upper GI series, a barium swallow. This is barium. This is the pharynx. And what is there with a Z at the back of the pharynx? Zoo, zoologist, xylophone, no, that's an X. Zankers, yes, there's not that many things with a Z in the back of that pharynx. That's a Zenker's diverticulum outpocketing in the back of the pharynx. These are the stretched out posterior pharyngeal constrictor muscles. The management of this is surgery, to surgically resect that Zenker's. These are the posterior pharyngeal constrictor muscles as they're outpocketed backwards in the pharynx. The management of this is not to put a nasogastric tube in it, not to put a scope in there. If you put nasogastric tubes and scopes, the nasogastric tube and scope might go into that Zenker's and boop, pop right out the back of it and rupture it. Little old ladies with dysphagia and very bad breath. What's accumulating in there is the food you've been eating for the last 3 days, and it sits in there and rots until you get dumpster breath. No NG tubes, no endoscopy, surgical resection, barium study. This is an abdominal film. This is not abnormal. This is just gas in the bowel. These are calcified ribs in an older person. This is a bra strap. This is not inside the patient. These are wires outside. The abnormality here is hard to see. It also shows you why abdominal films are useful predominantly for obstruction. If you're looking for air under the diaphragm, get an upright chest film. This is very subtle. This is calcified gallstones, the little white dots inside the gallbladder. These little white dots inside the gallbladder are the calcified stones. The little white dots inside the gallbladder are the calcified stones. This is what gallstones look like on a gallbladder X-ray. Only 10 to 20% of gallstones are visible on an X-ray because only a small number of them will calcify. This is a barium study. The most common wrong answer is to think that this is diverticulitis. Diverticulitis pockets off the outside. Look at this outside line of this barium study. It's straight. It's straight. The thing is that this has no sudden outpocketings. This part going inside, that is a pseudopolyp. Normal mucosa has been removed, and that little thing bulging into the lumen is a pseudopolyp. It is a pseudopolyp because a polyp is an abnormal growth going into the bowel. This is a pseudopolyp because this is normal growth, where the abnormal parts are the parts that have been removed in between. The outside edge is smooth. This is normal mucosa going into the lumen. This is the damaged or removed mucosa, and this is what remains of the normal mucosa behind. This is inflammatory bowel disease. Inflammatory bowel disease. Crohn's disease in the small bowel, ulcerative colitis in the large bowel. This is a large bowel obstruction. Look how much gas there is in there. Why, that's enough gas to light up Chicago. Look at all of this. Enormous gallons of gas in here. This is all methane in here. Large bowel obstruction. So much gas that it's straightened out the bowel wall so that it looks like one big air-filled bag. This is a large bowel obstruction. And so is this a large bowel obstruction. This is a person who could pop. Now, how do I know this is not toxic megacolon? Because toxic megacolon is not filled with air. Toxic megacolon is filled with stool to the point of stretching the bowel. This is air inside the bowel, and consequently, this is a person who's got a large bowel obstruction and can't pass gas. This is diverticulosis. This is a person who has outpocketings of the normal colonic mucosa off the side of the bowel. This is the diverticulosis. This is barium in the diverticuli. How do we know if this is diverticulosis or diverticulitis? And the answer is that diverticulosis can be diagnosed with either endoscopy or barium. We should not be doing endoscopy or barium when we have diverticulitis. In diverticulitis, we should be diagnosing it with a CAT scan, because this barium study, when you put in barium and in a scope, you're introducing pressure into the bowel wall. In diverticulitis, the bowel wall is friable, damageable, weaker, thinner, and consequently, endoscopy and barium can make it perforate. So therefore, for diverticulosis, you could use barium, but in diverticulitis, you should not. So if we look at this image, we see the outside edge of the bowel wall is not smooth. Not like it is in the patient here with inflammatory bowel disease and Crohn's, where the outside edge is smooth. It's the inner part that's abnormal, but the outside edge is smooth. In diverticulosis, the outside edge has these outpocketings that look like solar flares. Here again, diverticulosis. Outpocketings off the side of the bowel looking like solar flares popping off the side of your bowel. This person has a Metamucil deficiency. This is a person who's on a fat-filled, bacon, cheeseburger, low-fiber, disgusting American diet. The management of this is to eat more fiber and decrease the pressure inside that bowel. Diverticulosis. The next patient, this is a picture of a lawsuit. This is a person who's had a clamp left in them. This is the patient who, as they were being stapled up from the abdominal surgery, must have said, "Hey doc, can you do me a favor?" "What?" "Can you leave an extra clamp in there? I could use the money." So this is a person who had a clamp retained inside their abdomen that's been stapled into them. These are safety pins on the outside of the person, because we know we don't get inside the body and hold the bowel wall together with safety pins. But we do put clamps in there. And that's why it is often common that after abdominal surgery that a patient gets an X-ray before they leave the table to make sure that we haven't left any wedding rings, empty beer bottles, cans, clamps, loose change stuck inside the patient's abdomen. Now, can you see the top of the diaphragm? No. When you're looking for air under the diaphragm for perforation, the film to get is the upright chest film. You might see the top of the diaphragm on an abdominal film, but you always see the top of the diaphragm on the upright chest. This is the diaphragm. This is air under the diaphragm. This is the diaphragm, this white line, and this is air under the diaphragm in this dark part. Diaphragm, air, liver. This is air under the diaphragm. What's it from? You don't know. It could be a perforated duodenal ulcer, gastric ulcer, perforated this or that. It could be a stab wound, a gunshot wound to the abdomen. It happens to be this patient post-operatively. Everybody who's getting cut from their pubic symphysis up to their xiphoid process and has had their abdominal contents investigated is going to have air under their diaphragm. That is a normal post-operative finding to have air under the diaphragm after abdominal surgery. That is a normal post-operative finding. This also is air under the diaphragm. But this is a person who's too sick to stand up for their upright chest film. This is the diaphragm. This is the air under the diaphragm. This is the bowel. This is the bowel. So this is the bowel of a person who's got air under their diaphragm. This is the liver. This is called a cross-table lateral. This is a person who is lying on their side and the air is building up here underneath the diaphragm. It's just a person who's showing more air under the diaphragm for a person who's too sick to get up. Bowel wall and intestines, liver, air, diaphragm, and up here is the chest. There's a little pulmonary vasculature. Cross-table lateral. How do you look for air under the diaphragm when the person can't sit up for the upright chest film? The answer is cross-table lateral, looking for the air under the diaphragm. This is a barium study of the upper GI tract. Once again, it shows why the radiologic test is never the most accurate test, because this is a person who's got this crater here, and this is a barium study, and you're seeing an ulcer. This is an ulceration of the duodenum. Now, the reason that the radiologic test is not the most accurate test is that you can't tell if there's Helicobacter pylori. How do you know if this person has Helicobacter pylori? How do you know? You don't know unless you biopsy or do a breath test or a stool antigen. If this is a gastric ulcer, how do you know that the person's not one of the 4% of people who have cancer? How do you know? You would have to treat the person and repeat the barium study. If you did the endoscopy, you can biopsy for Helicobacter pylori and know right away. If it's endoscopy, you can biopsy and see if it's gastric cancer right away. Does barium diagnose an ulcer? Yes, it does. It just can't tell you if there's Helicobacter pylori or if there's cancer in it. Now, could you do the barium study and urea breath testing and stool antigen testing? Yes, you can. But it's better to say endoscopy first and only to do barium studies in people who refuse endoscopy. This is upper GI series, and this is an ulcer. What's the study? This is a normal esophagus. This normal wavy appearance is natural for the esophagus. There's no cartilaginous rings in the esophagus like there is with the trachea. There's no cartilaginous rings to keep it open. It's normal wavy esophagus, and this is a normal finding. This is nice, smooth, gentle curves throughout the esophagus. Why am I showing you the normal esophagram? So when there's an abnormality, you will be able to detect the difference. Normal, not normal. Oh, look at all this ratty, eaten up damage up and down the whole thing. What's that? It's not cancer. Cancer doesn't happen all the way from the top to the bottom, and you have 18 inches of cancer in the esophagus. No, cancer happens as a circumferential lesion, usually like the colon cancer, spreads out locally. It's not going to go up and down the entire esophagus. This is esophagitis, and this shows you why the radiologic test is never the most accurate test. If the person has esophagitis and it tells you that the person is an HIV positive person with less than 200 T cells, usually less than 100 T cells, then the next best step in the management of this patient is to give them fluconazole. And if the person is better, you just continue. And if the person is the same, then you should generally scope. Why scope? Because if it's Candida, it's going to get better for sure with the fluconazole. And if it doesn't get better, well, then maybe it's herpes. Maybe it's CMV. Maybe it's Kaposi sarcoma. Maybe it's idiopathic. Maybe it's an aphthous ulcer. So therefore, the most accurate test is upper endoscopy. Upper endoscopy is the most accurate test to look at the esophagus. So therefore, the radiologic test is not the most accurate because this is the appearance of Candida going up and down the esophagus. This is the appearance of Candida going up and down the esophagus. And that is why, even if the person with HIV does not get better, it is better to do endoscopy. You get more diagnostic information out of it. This should be treated with fluconazole. This is in HIV, and this is in patients who have diabetes. This is also a barium study of the esophagus. These are varices bulging into the esophagus. These are varices going into that esophagus, and these are the varices going up and down the esophagram. Now, again, it is better to do endoscopy because you can't band or sclerose. You cannot band the varices. So these people with the varices bulging in, it would be better to get endoscopy so that you can band them. However, this is a normal esophagram, nice and smooth and wavy. This is esophagitis up and down the whole thing. This is endoscopy showing you the Candida going down the esophagus. And this is varices. Cancer would not be up and down the entire esophagus.